evening, everyone, and welcome to the PerfWeb webinar series. Glad to see everybody here. YouTube chat is on, and our program this evening is on cerebral embolic protection devices. A couple of things that I have to go through, housekeeping notes, if you don't mind, very quickly. We are really working hard at growing this community and looking forward to you being a part of this community with us. So I'm going to ask you to do some things. First is, need you to subscribe. Now the subscribe button is actually down there somewhere, but click the subscribe button and also the notifications. This will let you know when we may have a special event or we've gone live, and you can just log right in on your phone and not miss any of the great content that we plan on continuing to bring you in the future. Also, please, if you'd like, you can download one of our flyers right here and have that around, and that gives you a lot of information in this flyer. It's kind of funny too. I kind of like it. And like us on Facebook. To call in, I think there's a Facebook logo right there. Yep, make sure you like us on Facebook. We are broadcasting simultaneously to YouTube and to Facebook. So, but I follow the YouTube chat. So if you want to ask questions, you can do that. And if you want to call in and be live on the air, click this or write this number down. That's the YouTube chat, and you'll see a signal that says right here. Yeah, there you go. 281-738-7906 is our call-in number. Phone is right here, and you can be live on the air, ask any questions, make any comments, be part of the overall discussion. Okay, with the mugs, let's go straight to the mugs. I have downloaded the names of everyone who has participated in our PerfWeb webinar series, and you are going to, these mugs, I'm serious this time, are being shipped either tomorrow or the next day, but they are coming to you. We finally got them ordered and got enough delivered. There were more of them than I needed. I didn't think I was going to need that many, so I appreciate that all of you are participating in this and coming to these programs. Let's see, what else do I need to talk about? Okay, like I said, our program, I'm just going to blaze through this, and I'll tell you why. Our program tonight on cerebral embolic protection devices, our faculty, our guest faculty is Dr. Alan Lumsden, who is the director of DeBakey Heart and Vascular Center at Houston Methodist Hospital. And in case you didn't see the U.S. News and World Report that just came out, Houston Methodist has been ranked the #1 hospital in Texas, the #1 heart and vascular center in Texas, and the number 14th Heart and Vascular Center in the United States. That is no small accomplishment. And in addition, Dr. Lumsden, who had to close his curtains, and he's going to show you a picture here of where he currently is beaming in remotely. And you know I'm all about this remote stuff, and I got that from, actually I taught Dr. Lumsden. He can tell you that story about how I kind of brought him along to the remote concept and how important that is. But he's coming to us from Jackson Hole, Wyoming, and has been kind enough to give us this lecture and discussion today from there. Dr. Lumsden, good evening. Dr. Lumsden, good evening. There you go.
Hope you can hear me.
We can.
Okay. Okay, well, that's the Grand Tetons, and the Teton Mountain Range is beautiful out here. So I'm indoors with the curtain closed. We're going to talk about something a little bit more mundane than Jackson Hole in the backcountry. Are you ready for me to start, Joe?
Yes, sir, we sure are.
Okay, so I always tell people we're going to live in the world of stroke for the next 5 years, and those of us who are performing procedures either in the aortic arch, the ascending aorta, aortic valve, left side of the heart, are going to be held to a pretty high standard in terms of stroke prevention. And we'll talk a little bit about what a stroke is shortly. And this cartoon essentially shows you a variety of different concepts. And we won't go through all of them, but we're going to go through some of them and talk about why this is important to me and the audience of those in the perfusion community. So a few simple questions. These are the teaser questions that I've used to used at the New Orleans conference. You're a perfusionist. Joe, I'm going to ask you the question. What's the least tolerant of poor perfusion? Your legs, your kidneys, your heart, your brain.
Can I call a friend?
You can call a friend. Try the friend sitting right next to you on the right.
Stephanie, which is it?
Kidneys.
The kidneys? No. All right, we get it. The brain.
All right.
All right.
So yeah, I'm a vascular surgeon, so we can clamp your aorta probably for about 6 hours. It doesn't make any difference to your legs. We clamp it above your kidneys. We probably got a couple hours. Your heart, generally you stop the heart, just kind of keep it cool. So after that, perfusion, that's important, but basically use it to stop the heart. But your brain, you really only got 3 or 4 minutes. And it doesn't tolerate having blood supply shut off either globally or if you start firing some particles out there. So this is one of those pass-fail questions. We could get Roger to answer this one. Is your brain better with, it's one of my old partners, is it better with flow or no flow?
Roger said flow.
I'm not going on until somebody goes, flow. He says flow. Very good, Roger. That would be correct. Now, there are
Is this working?
with no flow, but we won't kind of go into that in this webcast. Now, so what is better? Middle cerebral artery flow is a little more challenging, or flow in the veins of the cerebral cortex? Come on, Joe, you take that one.
Well, I would say if you're doing, I guess it depends on whether you're doing antegrade or retrograde cerebral perfusion, but I'll say flow in the middle cerebral artery.
All righty, that was a tricky response there, but I'd say you're right. And so we'll come in and examine why that may be important down the line. And so here's the thing with cerebral embolization. Are you better knowing this is happening? Are you better being blissfully ignorant like I am now? Or we could say that after a case, stroke's an act of God, I did the best that I can do. Don't bother me with any of this new monitoring stuff. I didn't learn how to do this in my training. Oh, if I ask them to do something new, the anesthesia will just be pissed off if I get in the way. Preventing delay is more important than preventing stroke. So we're going to examine some of these concepts basically as we move through it. And we start really with this because this has changed the world we live in. In 2017, in JACC, Journal of American College of Cardiology, this is from, it's called the NeuroARC, Neurological Academic Research Consortium. And if you look here, this is a whole lot of people. And they're not all neurologists. Jeff Potma was one of the PIs in some of the TAVR trials. Jeff Mose is another example. Michael Mack, as everybody knows, is a surgeon. So this is a pretty high-powered group of people who came together to try and create a new classification system for stroke. And this is going to be increasingly widely accepted. Okay, well, so why does this affect you and I? Well, let's go on through this. You probably can't read that very well, but basically, I don't need to go into all of that. I'm going to show you some highlights of it. So they talk about the primary mechanism of stroke. Now, they're talking about during advanced cardiovascular interventions, as I started off this presentation discussing. They said the primary mechanism of a procedure-related stroke is focal or multifocal embolization during cardiovascular instrumentation or surgical manipulation. That's why venous oximetry is of limited value in trying to determine why most strokes actually occur. Of course, diffuse cerebral perfusion from sustained or profound procedural hypertension can also be a cause, but is a less common cause. And the ongoing risk of spontaneous stroke actually extends beyond the peri-procedural time frame of what we actually look at. So basically what they start off by saying is that most common cause of stroke in the kind of procedures that we are all involved in is embolization. So let's say we use EEG monitoring, or let's say we use INVOS, venous oximetry. It doesn't tell us about the major cause of stroke. It only tells us is about if we got significant hyperperfusion, tells you nothing about the main cause. So we're going to come back and examine this. So they defined 3 different types of stroke, and type 1 stroke is what you and I would all recognize. It is a lesion in the brain, usually identified by diffusion-weighted MR, or a lesion on a CAT scan. But what they're now doing is defining a type 2 stroke as a lesion on an MR scan in the absence of any clinical manifestation. And we're going to come on and examine this. And so this is something that you and I don't even classify, as a stroke at the present time. And typically what we've often said is, okay, there's a lesion on the brain on MR, no clinical manifestations. Should we really care? Does it really matter? And what they're going to start making this argument is absolutely, it represents dead brain, most likely from emboli. And that you and I have to figure out how we reduce the incidence of dead brain. I always say, if you can tell me what the good emboli that are going on up into my head, then I will tolerate that. But so far, nobody's been able to do this. And so what they refuse, so DBRW MRI is diffusion-weighted magnetic resonance imaging. And we'll talk about this a little bit down the line. It is the single most sensitive way of detecting brain ischemia. And it becomes positive within minutes of an embolus going on up into your brain. And they refer to the term as covert, in other words, there's no overt symptoms from it, covert CNS infarction, to acknowledge that these events are not necessarily free of clinical consequences. You've often talked about pump head, for example. I thought they were referring to Joe. I heard this, but maybe not. So pump head and that detection of neurological...
Don't laugh.
And the detection of neurological or cognitive sequelae. I shouldn't start laughing. Because diffusion-weighted MR imaging is frequent. It's very common after cardiovascular. If you look at this, in the big picture, the pyramid is supposed to represent the totality of all of the incidents of embolization or stroke. And you can see that type 1 strokes, the ones that you and I recognize, and that can be ischemic, it can be subarachnoid hemorrhage, diffuse hypoxic injury, is actually the minority of these events that are actually occurring. Type 3 is kind of delirium. What we're talking about is the base of this pyramid. We're talking about the overwhelming majority of the events that happen inside your brain around the procedures, coronary bypass, TAVR, aortic valve, arch endografting. This is the majority of the lesions which are detectable on diffusion-weighted MR. All right, so that's kind of the basis for it. So, before I run that, let me go on to say that, so what the summary of that trial was that this happens with an alarming incidence. It is, and we repeat these procedures in patients, and that all future studies must mitigate this kind of occult cerebral embolization. And so what you're going to see is that same manufacturers that the TAVR, for example, who've been aware of the fact that this is happening. Reality is we've all been aware that this is happening. But what you're going to see now is the same manufacturer who has kind of downplayed the instance of this is now going to be coming to us and saying, oh my gosh, no, we can't have this. By the way, I've got another $2,000 device that I'd like you to buy, because you just can't have this stuff ongoing. The latter is probably true. And so you're going to see a complete switch. And there will be spillover effects into the kind of open surgery that we're talking about, because the reality is we have much less knowledge about what happens during open operations than we have with TAVR. And it's the observations around TAVR that are driving the increase in incidence of interest in this. So I'm going to show you some of the concepts that there are. I meant to say that I have no disclosures from this. I'm not dealing with any of these companies. So I'm going to show you some, just so you get some idea of what we're talking about in terms of concepts in embolic protection. So of course, before we go on to the next one, always looks pretty easy when you actually put these things in animations. And the first concept of embolization protection like that was called umbrella. And umbrella was actually developed by a friend of mine called Jeff Carpenter up at University of Pennsylvania. And it kind of came in from the arm. So you actually passed a catheter in through the brachial and it kind of opened up like a two-leaf clover, but it only protected the left carotid and the innominate. And so it really didn't protect the left subclavian and the left vertebral. With that device, you've just seen attempts to protect all of the cerebral circulation. The problem with umbrella was that it actually didn't protect it. And, you know, there were some embolization related to actually placing the device. And that's one of the concerns. And they can be thrombogenic. And lastly, you got to know how big the particles are. So you can size the pores to the particles that it's supposed to protect. And maybe the smaller particles you obviously can't completely occlude the flow. So there has to be pores within the membranes. And the last thing is, although it actually showed you the device nicely tracking across the surface of it, the devices tend to get hung up in it or deform it. So long way to go before this kind of stuff is ready for prime time. Now, Claret Medical is currently the kind of the hot topic because they just got bought by Boston Scientific. And obviously Boston are looking to position this along with the Lotus valve. So this is kind of a different concept, and you'll see this is also partial protection. So we'll let this run.
During a TAVR procedure, atheroma from the aortic wall, calcified aortic valve material from the TAVR catheters, and other debris can break loose and travel to the brain. Even small pieces can block blood flow to middle cerebral arteries and more distal tributaries in the brain, resulting in ischemia in the surrounding brain parenchyma, damaging millions of neurons and synapses and potentially leading to periprocedural stroke with devastating long-term consequences. The Sentinel Cerebral Protection System is the only percutaneously delivered embolic protection device that captures and removes this debris before it can reach the brain. Studies have shown it can be placed in just a few minutes with no additional safety risk. Sentinel protects 90% of the blood flowing to the brain. Its discrete placement via a 6 French radial catheter outside of the lumen of the aortic arch avoids interference with TAVR devices and the often hostile arch surface. This, combined with its self-expanding intraluminal filter apposition, allows stable, safe, and effective sealing, independent of the arch anatomy and pathology. In the Sentinel randomized trial, debris was removed in 99% of TAVR patients, and 1 in 4 patients had an average of 25 pieces of debris larger than 0.5 millimeters in size, that is visible to the naked eye, removed. In the same trial, nearly 15% of the debris was equal or larger than 2 millimeters. The same trial showed a significant 63% reduction in neurologist-adjudicated periprocedural stroke rate when Sentinel was used, which was corroborated by the independent, real-world, all-comer Sentinel-Ulm study that showed a 70% reduction in 7-day stroke or mortality rates. Stroke happens. Protection works.
So obviously a different kind of concept. Most of the experience with embolization protection currently comes from the carotid stenting world. And this is just a list for anyone who's interested in the different type of devices that are being developed. At the present time, in order to get reimbursed for carotid stenting, you have to use an embolization protection device. And the ones we use are very like what you just saw there with the Claret. Obviously, it's just one basket, not 2 baskets. And the whole idea is you position that at the base of the skull, you work downstream of it, and you collapse the basket. This is something we've been very interested in being able to quantitate just how effective these baskets are, and we'll come back and talk about that a little bit later. And so, to give you an idea, this is actually from planning to do direct aortic access from TAVR. And so this is we plan this, and this is called multiplanar reconstruction, where we're looking at axial, sagittal, and coronal sections, and you can plan the whole thing in the workstation. And all this white stuff that you see, and that's the reason that I'm really showing you this, is just is calcification. calcification, we believe, is a unique digital signature for an individual. We believe this is like a fingerprint, that no two humans have the same calcification pattern. It's something we are very interested. We can use it for what's called image fusion. Shows you that, and that, again, the kind of patients that we're working on, they all have extensive calcification, and extensive calcification is a hallmark really for the amount of debris that you find in the inner surface of the aorta, for example, when you're going to put a cannula in there. It shows you a little bit in close-up. I'm not going to spend much time on doing this. And then when you actually start running major devices, in this case, basically a TAVR, first of all, you got to puncture the aorta, then you got to drive it right through this calcified aortic valve. One of the things that's really important that we've been working on is trying to figure out when embolization actually occurs. Here's the problem, is that when you put somebody to sleep, let's say we're going to do an open aortic valve replacement.
Oh, we lost your sound.
And then the surgeon turns to the perfusionist and said, "Oh my gosh, you all right?" Surgeon turns to the perfusionist and say, "How did you screw this up?" The anesthesiologist turns to the surgeon and say, "How do you screw this up?" Surgeon always blames the anesthesiologist. But the reality is you have no idea when this happened. And in order to make these procedures better, you got to be able to have a surrogate for when embolization is actually occurring during the operation. And we'll come back on and talk about how to do that. And that's just how this can be completed. So I'm going to go through and give you a few different examples of some of the data that's out there. Let's talk about coronary bypass and type 2 strokes. Remember, just if you recall, type 2 stroke is DWMRI, positive lesion, and the absence of clinical manifestation. So all of the studies that are reported, where they talk about 5, 6, 7% stroke rate, are type 1 strokes, the overwhelming minority of the lesions. And so there's data out there really looking at, here's one from, I believe this is Poland, evaluating brain lesions in patients with coronary artery bypass graft using MRI, and really looking, I'll show you, what the outcomes were. And there was a significant difference in they were looking at on-pump versus off-pump. There really actually turned out that there wasn't a whole lot of difference. And they had some interesting conclusions about why that may be the case. And that they actually thought that hyperperfusion, you still have me?
Yes, we still have you.
Hyperperfusion of any kind, hyperperfusion may be detrimental in that it may not actually wash out any of the particulates that actually go on up there, but overall there wasn't really any difference. But I hadn't really heard of that as a mechanism of potentially resulting in increase in stroke. So the incidence basically overall, of course, the stroke is somewhere in the 1 to 5% range, but about 30% of these patients, I'm not even going to say the word that I said that made me laugh earlier, but 30% neurocognitive dysfunction. Why does that actually happen? And this concept, as I already alluded to. And so clearly there are a lot of these events which actually take place. And if you look overall in patients with coronary bypass, you may see type 2 strokes of the order of about 31%. Now, you may be horrified that in 31% you've got stuff going on up into your brain, but that's way ahead of what you're going to see in TAVR. And so who knows? I don't know what it is with the aortic valves yet. We'll kind of walk on and look.
He's frozen up. Hey, Doc, you're frozen up. Can you hear me? He's frozen up.
You may have dropped some.
Yeah. All right. We may be having technical. Go to a different image, and we may be having. Is it? Oh, it's
he's
me.
Back.
Is it? Oh, he's back. Okay, good. There you go.
Okay.
Okay.
I didn't go anywhere, I promise.
So I think we missed that. We missed that just previous thought that you had. Nice.
All right. So let's go on. Let's go on. Don't worry about that. There's plenty more. We'll talk about TAVRs, and so this is really where a massively increased incidence of interest is, in looking at incidence and mechanisms of cerebral embolization. I'm obviously not going to go through all of these papers, but it is the concern of debris you know, I happen to think that embolization is as common during catheter-based, and in fact, I think it's normal. I think when we blow up balloons in the aorta or the iliac arteries and then deflate them, you're almost always going to get embolization. But the majority of this is actually asymptomatic or subclinical. But when it's going in your brain, that is obviously a different level of concern. And so this is really what the drive has been. And you say John Webb here is really one of the fathers of TAVR out of Vancouver in British Columbia. And they looked at the incidence of TAVR using a variety of different protection mechanisms. And this is kind of where we're at the moment. I'm going to show you a little bit more data about this down the line. My arch endograft, and again, obviously you put in infrarenal grafts, you don't get embolization. You put in descending thoracic, and believe it or not, there's a not insignificant incidence of stroke. If you look at all of the TVAR trials, so that's thoracic endografting, for dissections. We're talking about type B dissections where we really shouldn't actually even be going over the arch. One of the major complications in all trials, regardless of manufacturer, is actually stroke. So, and I actually stole these slides from a friend of mine. This guy's actually the president of the Society of Vascular Surgery this year, Michel Macaron. At this meeting that I'm at what's called this failure analysis conference, where we kind of look at problems like this and how we can make them better. And one of the things he presented last year was this dire need for understanding the mechanism of embolization during thoracic endografting, and increasing interest from industry in trying to help us figure out when it occurs and why it occurs, and subsequently how to prevent it from occurring and from ongoing. And again, if you look at the bottom line, is this is a summary slide which simply shows you that TVAR, I should say, I get my TAVRs and my TVARs confused, is a major ongoing problem. And when it occurs, it's associated with a significant increase in morbidity and mortality. And if you look at just some of these, this is chimney grafts, is just a way of putting in branches, 29 patients, 9 arch, 1 stroke, that's not bad. In the second group, 3 strokes, last one, a stroke which amounted to a death. And these are clinical strokes. Again, these are not looking at embolization, which is going to be exponentially higher than is being reported here. So the higher, mostly occurs with urgent or high risk cases. We can see the stroke rates, that's really all that we're talking about here, is of the order in many of these trials of up to 11%. Type 1 strokes, just to emphasize it. And so if you look, basically, this is actually taken from a review that Joe Bavaria did. You're looking at different methods of monitoring in complex aortic procedures. These are things that you're all aware of, but certainly worthwhile looking at. This not so much just monitoring, but how can we actually reduce the incidence of stroke that's occurring around these procedures. One way is to look at the carotids preoperatively. It could just be that low flow or wires which inadvertently go up into the carotid could actually be associated with the knocking a piece off. A thing that I'd never even heard of was jugular bulb venous oxygen saturation. Could you put something in the jugular veins and measure the oxygen saturation? The whole idea would be that if you're hyperperfusing the brain, then that will actually fall. It's one way basically of doing this. EEG, again, a lot of people have utilized, as I say, what it tells you about is global perfusion, not embolization. That's basically the downside of it. NIRS, again, really only tells you about the surface of the cortex and tells you about venous oxygen saturation. In my way of thinking, why measure venous oxygen saturation if you're looking at arterial flow directly? And that's transcranial Doppler, which you look at. And I know you've heard a presentation on this. We are on a mission to try and say that TCD should be part, basically, of these procedures. I keep teasing Joe and say, why don't you measure TCD? When I get my coronary artery bypass, I'm going to make sure my perfusionist and my surgeon make sure that I want my middle cerebral artery flow velocity measured. And I'd like you to keep that when I'm on the pump greater than 50% of the baseline. Because we know from the carotid world that if you're more than 50% baseline, I don't need to put a shunt in your carotid artery because that's more than enough to sustain you. So these are different things that I wrote there. There's a bunch of information about venous oximetry. Clearly, these things are not completely mutually exclusive. I'd like to have both, quite honestly, if you're going to be treating me. I won't go through all of these. And so the whole idea basically in venous oximetry is if you look basically at the two different tracings, hopefully you're going to see one side different from the other. In this case, temporary occlusion of the left common carotid artery, followed by temporary occlusion of the innominate during debranching procedures. The idea is you get this fall of ipsilateral reduction in cerebral oxygen saturation. And that's currently the state of the art. But there's a lot of things which basically affect this. And if we're going to use it, we need to be aware of that. But again, indirect measurement of cerebral venous perfusion. So, and lots of things actually can affect it. So what I like to do, I'd like to know immediately when something changes. And I hope I can try and convince you this. And so all of these different things which affect cerebral perfusion can result in stroke and neurocognitive dysfunction. And there's a variety of different ways, you know, how an aortic dissection can affect cerebral perfusion. Sometimes when we get a dissection, it actually extends up into the innominate or the carotids. And the true lumen may be completely collapsed by any kind of pressure that's present in the false lumen. And the false lumen, in this case, I'm not just talking about in the aorta. These are the true lumen and the false lumen can go all the way up into the carotids, can go into the innominate, can go into the renals, can go into the legs. So it goes, you know, dissection is one of these life-altering things when it actually happens. But the acute problems occur from the fact that it can knock off all of these different side branches. It can also happen if you happen to cannulate and put a perfusion catheter into the false lumen. That may make it dramatically worse. So again, some of the problems which can actually occur when these events, and these tend to manifest as neurologic deficits. And whenever you get that, basically it dramatically increases the duration that the patient is going to be in the hospital. I mean, a stroke is one of the more expensive complications that you can actually deal with, prolongs the length of hospital stays, drives the rehab process, and fundamentally may prevent the patient. You can do a great operation and the patient never gets back to normal because they're impaired by this. So again, I'm not going to go into this because frankly, you folks know a lot more about this, about how you can actually do your part as a perfusionist to try and protect the brain. But there's not much that you can do about embolization other than make sure there's not a bunch of air basically going up into the head. It occurs with every aspect of the types of procedures that we're doing. And we've been very interested in VADs because here the risk extends into the post-op period. If you follow a VAD patient long term, and again, perhaps you don't actually see this that much because you deal with the acute phase, but what these patients succumb to are strokes, very high incidence of stroke. And so we were actually monitoring some of these patients in 400 Brown ICU, and you could actually see emboli starting to occur up inside the head as the anticoagulation regimen dropped below a certain threshold. And so we used it then to tune up what the anticoagulation and what those thresholds basically actually were. So just to put in my plug basically for transcranial Doppler, and that is that, and the reason I'm talking about this is when I saw let me start again with this story, is that a lot of what has been said and nihilism about transcranial Doppler is it tells, the surgeon would always, well, you keep telling me there's emboli going into the head, but the patient seems fine afterwards. Don't bother me with that nonsense. To which, my response was always, okay, now explain to me what the good emboli are that are going on up in your head. And if we can figure out the good emboli from the bad emboli, then perhaps that may be relevant. And when I saw this new stroke classification system coming out, and I realized the emphasis was about to shift massively onto subclinical embolization, which produces these lesions, I realized that this is going to be a new birth for transcranial Doppler, because at the present time, there is nothing which can tell you about emboli. And secondly, we record this. We record what is going on in your brain at the same time as what the surgeon or the interventionalist is doing inside the chest, so that we know exactly when emboli occurred. Now, it doesn't necessarily mean that that is when the stroke occurred, but let's look at it in the reverse, because it's very, very sensitive. But if there are no emboli and the patient has a stroke, I'm telling you, it didn't occur during that phase of the procedure. And the way it works is you place an ultrasound probe, it's a low frequency probe, on the parietal, over the parietal side of the brain and the skull, because it's thin there, and you fire an ultrasound beam. And now, God clearly believed in transcranial Doppler, because he built us that the middle cerebral artery, the anterior cerebral artery, the anterior communicating artery, the anterior cerebral artery, and the middle cerebral artery were all in a straight line. And so if you fired an ultrasound beam straight down that line, then we can actually interrogate blood flow on the same side. So probe, in this case, is on, let's call it the right side. Blood flowing to the probe in the middle cerebral artery is red. So the reason this is set up like this, anything down from the depth of 15 millimeters down to 55 to 60 millimeters, 15 millimeters to 65 millimeters, that is all signal, Doppler signal, coming from the middle cerebral artery on the same side. And by convention, that's demonstrated as red, blood flowing towards an ultrasound probe. When you get deeper from the 60 to 70, now you're looking at the anterior cerebral artery on that side. And remember, blood comes up out of the neck and it divides and it flows towards the surface of the brain and towards the middle of the brain. So that's blue. And then when you get deeper, you start looking at the anterior cerebral artery on the opposite hemisphere. And so that's 70 to 80 millimeters of depth from the surface of the brain all the way through the corpus callosum, all the way to the anterior cerebral artery, and that's red. And then in most cases, you can pick up the middle cerebral artery on the opposite side. And so you can study, but in a lot of patients, you can see all of the major blood vessels in the anterior circulation. But this little yellow line is, you can actually, if you're the one who's monitoring this, you can dial this to wherever you want it. If I put it here at 50 millimeters, it tells me about the, and that's what we'd hear. And it shows you that auditory signal is depicted here as the 1 cardiac cycle. So this is 1 cardiac cycle's worth of blood flowing in the middle cerebral artery. And so it is a remarkably powerful tool. And if you see, first of all, if I was to clamp the carotid artery on that side, this would go flat. And then what happens is the head compensates for these major vessel occlusions. And so I think our creator also decided, I think he was a perfusionist. Clearly he was a perfusionist. That's the way I'm going to sell this concept. Because God was clearly a perfusionist, because he designed cerebral autoregulation. And that, you know, all your homeostatic mechanisms are designed to maintain blood supply to your brain. And if your brain can compensate, it starts moving blood around, provided there's some residual capacity somewhere else. So that's basically how we use transcranial Doppler to actually see what's going on. Now, okay, let me just go back up for a minute. Let me set this up before we get in here. So I know you're all perfusionists. What you're looking at here is an off-pump coronary artery bypass. That LAD is open. This is one of my partners, Mahesh Ramchandani, and he's using a stabilizer on this, okay? And so they use a CO2 blower to clear the field here. Now again, what you're gonna watch here, this is right hemisphere, left hemisphere. Remember, this is middle cerebral artery. This is the red in the middle cerebral artery. And if you get air or emboli going up in here, you see all these white streaks that will suddenly start appearing up here. So I want you to watch this. And you're going to see coming in from here, you're going to see a CO2 blower coming in. Now what happened right there, let me go back one. So what happened here is that immediately the person monitoring the brain said, what just happened? And he said, well, nothing. And he said, well, there a whole bunch of gas just came up into the head. Immediately you can pick that up. And he said, oh my gosh, you know, this is supposed to be occlusive. So he repositioned the stabilizer, and then he brought the CO2 blower in, and there was nothing. And so what was happening was the CO2 was immediately going into the systemic circulation. And this is one of the most powerful examples of the relationship between what the physician, the surgeon, was doing here and what is going on in the patient's head. You would never have picked this up without that. Now, fortunately, CO2, I think it's absorbed pretty well, but had this been air, you detect this thing immediately, and there's nothing else will actually do that. So this example is designed to teach you that embolization, the relationship, the effector organ for stroke is the middle cerebral artery, and we need to know what's going on in the middle cerebral artery while we are operating down inside the chest. Now, next example is a little bit less obvious, so I'm going to talk through it as we're showing this. And so this is about flow. It's about perfusion, okay? And what you're going to see here in the next case is this is a patient who's having a TAVR, a horrible word, okay? And so all of a sudden the patient has a cardiac arrest. Now they interestingly managed to leave the fluoro. If you look at this stuff, they managed to leave the fluoro on here while CPR was in progress. So you see a pair of hands come in and you see one of the residents starting to do CPR. We were monitoring the middle cerebral artery while this was going on. And so if you were standing in that operating room, you would see institution of perfusion. In this case, it's using CPR, okay? And what Dr. Garami was doing is monitoring cerebral flow, and he said, there is no blood flow in the brain. Now, how could that happen? And so one of my partners, Mike Reardon, yanks the resident out, jumps in there, and starts doing surgical CPR. I mean, now you're really talking. And all of a sudden, Zolt said, oh yeah, now you got it. Now we got good middle cerebral artery flow. That patient would not have survived, would have woken up basically in comatose. And for all intents and purposes, that patient had CPR in progress, but it was not effective. So you got to make sure that when you institute some sort of cerebral perfusion mechanism, that it's actually effective. And CPR, this would tell us that. And this is just the end of this. Well, this is a different case. Here's another example of here we're putting in Joe will cringe at this because this is more encroachment on your territory. We're now running a trial for treating type A dissections with stink grafts. And again, the biggest complications up here happen to be strokes. And so here, again, what we're doing is, and it's just to try and emphasize this concept of simultaneous recording of what's going on in the head as the devices come up and over. And you see these devices right over the outside of that arch. And what you're going to see is this, it's going to be positioned. These marks are from a fused image that we utilize. It shows you the right and left corneas. And then we're going to deploy the device. And as the device deploys, these devices often have air inside them. It's very difficult to flush and get all the air out. And sometimes that basically is the source of the embolization. So we're pacing the heart. I'm going to wind this forward a little bit for you. Oh, missed it. So what? Now watch over here inside the head as this device deploys. And see that? Okay, that's cerebral embolization. And you can't very easily, and over a period of time, it'll wash out and it'll actually clear. And it was the only time in this procedure they'll wind it forward and you'll see it gradually clears and gradually goes away. And goes back to baseline. And so the important thing was that we have tried to define the high risk phases of putting in these devices. This is actually published by us in the Journal of Vascular Surgery, where we're putting in these thoracic endographs. And it's looking at embolic count in the right hemisphere and then the left hemisphere, procedure up into its component parts. So here's what it looks like at baseline. Some people have baseline embolization. They are extraordinarily high risk for having a stroke during the procedure. And the first thing you do is you put a wire up, no big deal. Put the pigtail catheter up, not a big deal. Put a stiff wire up, not a big deal. When you put the device in and you deploy it, that's what you've got going on here. and then when you're ballooning it are the times really when you get embolization. And you can see it's happening in both the right and the left hemisphere approximately equally. So we know these devices, you know, cause this. So move on to some of the big time data about TAVR, and that is about the rationale for cerebral embolic protection and why nobody's going to go just do this in TAVR alone. I think that what you're going to say is, okay, we're starting to define what the risk is in TAVR. Show us what it's like with surgical valve. Maybe it's better. I mean, it may be good, or you may prefer to actually put in a SAVR. So who knows? So anyway, this is some of the background. If you look at SAVR, surgical aortic valve replacement, clinical stroke rate basically is of this order. What silent stroke rate, that's what used to be defined as, were of that order. But TAVR, we know basically is going to be higher. We know that microinfarction or type 2 is now being defined. That's really just to summarize again what we were talking about earlier. We're talking about this is what occurs in a lot of these patients. And if you look, this is just looking at clinical stroke rates in these trials, really that are out there. And you may say that's acceptable, but again, that's clearly the tip of the event. And not all of the trials occur during the procedure. The majority of them are ischemic, not from cerebral hemorrhage, which could occur from the anticoagulation or the antiplatelets and blood pressure going up, for example. And most of the events basically are going to occur, you know, around the time of the procedure or immediately after the procedure. And the majority, over 50% of them, are major strokes. Again, these are most of the type 1 strokes that have been occurring are major strokes, very disabling events that are actually going to happen. Now, if you look, if you just start sticking patients in the magnet after TAVR, I'm not entirely sure exactly when the time course was, you're going to see that nearly 80% of these patients have had stuff going on up inside their head at the time this is actually occurring. And you can see, and again, if you remember what I said was diffusion-weighted MR positivity occurs whenever the debris goes up there, will occur very rapidly within 3 to 5 minutes. Nobody actually knows how long it takes to actually clear at the other end of it. And the kind of stuff that can go up there is kind of listed on this. But it's these multiple steps of the procedures. That's why we're particularly interested in being able to relate the embolization that's occurring to the actual manipulation that's going on at the time of an open operation. They say here that most of the debris that you need to cause stroke are greater than 240 microns, maybe. It's one of the studies that we're actually planning to do is that you can make, Boston Scientific make what are called embospheres, used for embolization of tumors. And they're very highly calibrated. They're 10 microns, 50 microns, 150 microns, up to 500 microns. And one of the things that we want to do is in a test rig and subsequently in an animal model is to actually infuse some of these. And we're very fortunate that we have in our research lab, we have an MRI in there. We can do immediate imaging. And very soon we're going to have an MRI in our operating room where we can do immediate brain imaging as soon as the TAVR or the SAVR is actually performed, because we really need to define how much debris causes of these lesions and how big these particles actually are. And almost all of this is being detected on a 1.5 Tesla magnet, sometimes a 3 Tesla magnet. We're actually starting to build the only 7 Tesla magnet in Texas. It will show us 3 to 4 times the number of lesions as are currently clinically detectable. So again, the imaging drives, what I will say is that imaging drives diagnosis. As soon as you make the diagnosis, it drives alteration in therapies that are going to occur. I talked about Umbrella. This was the initial one that was being produced by Jeff Carpenter. Trigaurd, I don't really know where that is. Again, the problem with a lot of these, you imagine bringing a TAVR up and over the surface, because remember, it rides across on the outer surface of this. So there's going to be some real issues in terms of how the device and the protection device interacts with one another, and also trying to define the pore size. This was probably too small, because sometimes Umbrella would actually get thrombus forming on it as 105 microns, 130. You know, we really don't know. It's an educated guess at the moment. And this is just a summary of some of the other ones really that are out there to try and protect the head. I'm not going to go through that. This is what diffusion-weighted MR lesions look like. It's the gold standard. This is what it looks like if we fire some particles up into your head, but it can be much, much worse than this. And you know, there are different ways basically of looking at it, but diffusion weighted MR is really the way to go. And you can see both the anterior and the posterior circulation. This is a little technical, but you know, how you actually do this, the better you are with the MR imaging, you're going to see it. This is kind of some of the suggestions about how we should start evaluating patients after TAVR and after some of these surgical procedures to see just exactly what the true incidence of this is actually going to be. And these are a number of the different studies that are cranking up using these embolization protection devices to try and prevent this. I'm going to go on a little bit. I'm almost up on an hour. So you can divide these. Remember I talked about anterior cerebral, middle cerebral. This is what the brain looks like. You can actually, by looking at, for example, the TCD would be coming in here. You can look at the ACA, middle cerebral artery, and this would be where you would expect these lesions to appear. So if you see on TCD that the particles are going down the anterior cerebral artery, then you would expect to be able to find these lesions in here if they're clinically significant. That probably largely depends upon the size of them. Anyway, right, so bottom line is that protected TAVR, and there's also another study actually done in England with TVAR, actually seems to show that using some sort of embolization protection device will reduce the number of the new lesions that are actually being found in these patients. So this is just a couple of different ways of what we're going to try and do this. Now, to start closing this out, here's how our interest in this. I won't tell you who the model was for this particular model that's been built here, but this is a model that we can actually perfuse. We can practice transcranial Doppler through these little windows. This is now being, here's Joe, and this is Zoltan Garami. They're kind of working on this, looking at how you can introduce air into the perfusion circuit and demonstrate the fact that there's embolization going on up here. We took it one step further. We're building these 3D embolization, 3D aortic arches, and we actually connect that up to a pump, and we connect that up to that head. And then what we're going to do is put these embolization protection devices in here and infuse particles of known diameter, so we get some idea of just exactly how efficacious these devices are in protecting the head. And then we'll be able to test these probably in an animal model right after that. So I think that is my last slide. I'll put it back up, and I think you want me to stop sharing. I'll give you this back, Roger. And you know, I think this, just to emphasize, I think this is coming our way. You're going to go from if we go into TVAR and we show that these are very effective, there's going to be some significant questions about how can we deploy these during open surgical procedures, aortic arch endografts. And as I said at the beginning of this, I think we're going to live in this world of how do we, as a cardiovascular specialty, reduce the incidence of stroke, type 1 stroke, and reduce the incidence of type 2 stroke. Clearly, we cannot do MRI on every patient that we're doing a procedure on. That's why we're interested in trying to define TCD as a surrogate. In other words, if you see particles on transcranial Doppler, does that equal diffusion-weighted MR? And can we basically simply use TCD? And again, remember that you're not doing real-time MR. All these lesions that go up there are a composite of everything that happened to that patient during the procedure. The advantage of TCD is, you know, you see air going into the open coronary artery, and we act on it immediately. We see ineffective cardiopulmonary compressions being performed, and we change that immediately. Some things you can't change, and that's true. But we got to basically work on the things that we can. Thank you very much, Joe, for the invitation, and apologize for being, well, I'm not going to apologize for being Jackson Hole. It's pretty nice up here, but I know the connection is not the greatest in the world. But thank you very much for bearing with me.
Well, thank you too. I do think you do need need an apology. We need an apology from you. You owe us an apology for not being in Jackson Hole, but not having us there with you.
I agree.
I think, yeah, you agree.
I agree.
I think that's the real problem. So let's open the phone lines in case anybody wants to call. Number one, and I've got some questions. We'll see if we get some calls. And in deference, I'm sure you're probably starving. You're an hour, I think, before us, and you probably haven't had dinner yet. But help me understand how, when you do a TVAR and you're in the descending thoracic aorta, you end up getting emboli up into the brain, because I haven't figured that out yet.
Well, when you put a T-bar in the descending thoracic aorta, you still have to put wires over the arch. And so it's never the device. First of all, in the position of the device is usually drive a device beyond most descending type B dissections begin at the level of the left subclavian or just beyond the left subclavian. So you got to either land right on top of the left subclavian, or you got to partly cover the left subclavian. And a lot of the time you advance the device into the arch and pull it back into position. And so those are kind of the reasons. But what was really interesting about it was everybody would have thought that aneurysms, because they've got all that debris inside the aorta, would have had the highest incidence. In fact, it was dissections, and that is not absolutely.
We just lost them. We just lost you, Doc. Hold on.
Yeah,
there you go.
I'm here.
Okay, so starting back from it was dissections. That's where we lost you.
Yeah, it was dissections that had the highest incidence of stroke. And that's not intuitively obvious why that should be the case, because typically dissections don't occur in really atheromatous aortas. They tend to occur in the more, I don't say they're normal, but less atherosclerotic disease than in patients who've got aneurysms, for example.
That's okay. Well, thank you. Did you have any questions? Because I have some more, but do you have any questions for him?
I guess the real key is to figure out how much the TCD actually captures what size emboli is going, and if it really will show, correlate, right? I mean, how small will affect the TCD?
There are a logarithm. Yeah, that's a great question. It's very sensitive. It can detect down to probably the order of 10 microns, which is down to almost red cells. And so it will detect that entire range. But again, it's so trying to figure out what is the clinically significant stuff is the key question. And so I often hear this of the criticism of TC. So let's turn it around a different way and say there are major phases where there are no emboli, okay? No emboli. That means there's not anything, part of particulates of 7 microns basically or more. That is almost more powerful in terms of trying to troubleshoot the procedure than it is actually saying this is when it actually occurred. I can tell you when it's not going to occur.
I see.
So we've got a question, Julie, and Julie is in Wyoming, but Julie's not telling me her last name. I want to make sure it's not a plant, that there's not somebody else in your room. Show the camera around. And she is asking, what is the long-term effect of these type 2 strokes that you're talking about, the subclinical strokes? In other words, it doesn't have an effect, and you see them and you're measuring them, but what's the effect long-term?
Sure, that is the key question. So in TAVRs, there's an average volume of 6.3 cubic millimeters of your brain which is affected by this. And that equals 50,000 neurons are wiped out. But it's 500,000 synapses, okay? And so it may be the connections are affected more than killing the actual cells. And so that's the issue, is that we probably don't have the detection capability. Again, let's go back to Alzheimer's disease. One school of thought is this is from subclinical embolization, which is going on. And if you're knocking off small parts of your brain, maybe if the only time it happens is during your TAVR, maybe it's not relevant. But if you have TAVR and you have ongoing embolization and you get a coronary intervention and another intervention, the cumulative effect of that over time is what really needs to be looked at. The short answer is I can't answer that question directly. But the general consensus is having little pieces of dead brain is probably not a good thing, and if we can mitigate it, we should.
Yeah, I just think that makes sense. I do think it's intuitive, but I think that there's so much work being done on the TAVR front, the TVAR front, the dissection front, the coronary stent, the carotid stent front, all of that kind of thing. But what about the pump? I mean, I've got so many different questions about what we do with the suckers, with the vent, with given the cardioplegia, with coming down on the flow and up on the flow, and the technique that you use. Do you clamp the line, or do you turn the rheostat control down, back and then back up? Different people use different methodologies for doing that. And it makes me wonder, well, we don't know what we're doing. We don't believe but I think the pump contributes to, I think there's GME all the time. Number one, I think it's increased when you have high suction flow. And so one, what are we doing about the delivery from the pump into the patient, which if we're not measuring it and we don't know, like you said, ignorance is bliss, but I might need the pump one day. And so that's my concern. And then the second part of that question, is a two-part question, is there any work being done in that? And then the second
I'm really glad.
Huh?
I'm really glad I didn't. You asked me a question and you said, well, what do you do with the suckers? Well, I'm glad I didn't jump in and answer that, because I wasn't entirely sure who the suckers were, and I could have got myself in trouble. You mean the suction thing is that we put in the pump
chest, suctions? Yes, the pump suctions. Yeah. Yeah.
Okay.
Yeah. Is Julie in the room? I know she is. Okay, so that was the first part of the question. Is any work being done as far as in embolic protection with the pump itself, caused by the heart-lung machine, or has it even been measured? Has it been considered? And the second, how much of what you're trying to do can be mitigated by technique alteration?
So you're in a better position than I am to talk about what's been done with the pump. But I suspect you almost need to be able to look at this at different levels. I'll give you an example. We did a bi-level monitoring in a carotid artery above and below a protection device. And it let us quantitate the efficacy of the protection device. Now, again, you can clearly imagine a situation where you have different systems on the pump at different points being able to see what is going on. Now, but you guys are experts in debubbling, pumps, a lot more than I know about it. How do you change your technique? That's the question that always gets asked. So I showed you deliberately two different examples where there was an immediate effect on technique. Now, let's say you are doing, a retrograde perfusion and a type A dissection, and and you're cannulating and reperfusing through the right carotid, and there's no flow in the middle cerebral artery. Well, you better change something. One thing I guarantee you, they ain't waking it up at the end of that case. And so that's where, if I get a type A dissection, Joe, I'm dependent on you to be in that room and make sure that if you're perfusing me through my right side, that somebody's making sure there's flow in my left middle cerebral artery. And I don't really want them just to be looking to see how much blood is coming back out of the carotid artery, because that goes across an external carotid to the external on the opposite side and goes down. We know, that's how most of that blood actually comes. So I'd like to know what's going on up in the old noggin here when you're doing this. And there are ways of cannulating the carotid directly. I think there are modifications of how you can do perfusion technique and endovascular procedures.
Well, we need to know. At the end of the day, we need to have the data.
Well,
that's the problem.
Sounds like you need to do the study, is what I'm hearing. You need to do a study.
And I could assign you to it. I'll do the study. I'm assigning her to it. And also, Dr. Mack, he recently, I guess it was last year, at the American College of Cardiology clinical trials, looking at SAVR compared to TAVR. And they looked at two different embolic protection devices. This Triguard cannula that I'm going to talk about after you bid us adieu and after the break, and also the old Edwards Embolic catheter that was in existence for capturing debris or embolization in the aorta from manipulation, clamping, unclamping, all of that kind of stuff. and what he found was that in almost every case, a high percentage, they captured things, but it didn't make any difference. The outcome didn't change statistically when they looked at the controls versus those that used the devices. How can that, I mean, you have less of it, but if the outcome is the same, kind of what's the point?
Well, that is the point. The point is that you are embolizing your brain. We can demonstrate using neuroimaging that you're embolizing your brain, and that occurs almost ubiquitously in these patients, and that should be mitigated. I've yet to hear the argument that it's good. It's not like you're planting seeds up there to grow more new. You know, you come to this world with the same number of neurons in your head you're going to die with, and knocking off, 500,000 of them at a time is probably not ideal. We may get away with it, but it's probably not ideal. And I think it's also a surrogate for type 1 stroke. And I think, here's my premise. I think if we learn to reduce the incidence of embolization, you will lower the type 1 stroke rate that you're talking about, that you and I basically have focused on.
So the last question that I have, and if you have any, just jump in, is where do you think this industry is going to go? Do you think the devices that currently exist are better than nothing? And two, in 5 years, what do you anticipate this cerebral embolic protection device industry looking like?
I think what the NeuroArt group, of which Dr. Mack was actually a member, has shone a spotlight on a phenomenon that occurs with almost all of these interventions. And that a new standard will be created to say that you don't define stroke. Stroke is dead brain. And that I think this is going to grow. I really don't know if the current generation devices are going to cut it or not. I mean, people say, could we just go put 2 carotid detection devices in? Well, every time you put 2 or 3 wires up through the aortic arch and through the carotid, the cannulation process alone can cause embolization. So just the presence of these devices does not mean that it will prevent stroke or prevent embolization. And so I think these trials are going to have to be done. I mean, I think the spotlight is now shone. The FDA is saying you got to reach this, and to run a clinical trial. And first of all, the stroke rate is relatively low. If you're trying to reduce stroke, you can't run the trial on type 1 stroke. You'd have to randomize thousands of patients to be able to do it. It would be cost prohibitive. But if you've got an event rate on TAVR, which is 70–80%, then you can basically start reducing it. And if you can show a surrogate, such as TCD, which is a lot cheaper and gives you a much more information about when it's occurring, then I think that can be very helpful. And what TCD does is it looks at waveforms and flow. What perfusionists do is deal with flow. And so that's why I started this thing off and saying, you're a perfusionist. What do you perfuse? I would submit to you that the single most important thing that you perfuse is the brain. And I would submit to you that there are much better ways of monitoring that than you're currently using.
Oh, I would agree with that entirely. So 2 things, and then we're going to bid you good night. Do you have any questions?
I was just wondering, it sounds like the standard of care right now in the SAVRs and TAVRs is not to have the embolic protective devices, right? What percent would you say you're using them?
Yeah. Oh, no, it's a minority. They're only being...
Minority, right?
So, again, almost all good things come from Europe, and I'm an example of that, Joe, with my Scottish accent. All good things come from Europe to start with, and all of these trials are being done in Europe and South America at the moment. Interestingly, this may change because the European regulatory bodies have become much more restrictive in terms of testing over there. So you may actually find much more of this early work is going to start being done in the United States. The joke I heard when I came over here was that you try it on the Europeans, and if it looks promising, then you go to the animal lab. That may change.
That's dreadful. That's terrible. You got the whole studios laughing on that one. So two things then to wrap this up. One, again, congratulations on the U.S. World and News Report.
Thank you. We're very proud of it.
You should be very proud of it. That is no small accomplishment to do that in a state like Texas. We're not in Delaware or in Kansas. This is the state of Texas. So that's pretty impressive. You accomplished that. And the second thing is, I'm so proud of you that I finally drug you along and got you convinced that TCD was a good idea.
And remote monitoring. Don't forget that. You taught me that too.
Yes, and remote monitoring. Thank you very much. Okay, we're good. Dr. Lumsden, thank you so much again. And
good job.
We're going to go to a commercial break. Thank you. Enjoy your dinner.
Thanks. All right.
Imagine trying to drive a car looking only through the rearview mirror. Critical decisions would be based on old and possibly inaccurate information. The same can be true of performing cardiopulmonary bypass without continuous inline blood gas monitoring. Terumo's CDI Blood Parameter Monitoring System 500 continuously delivers 11 critical blood parameters throughout the procedure. With other systems, periodic blood gas measurements provide static information. That is helpful, but limited. Continuous monitoring tells you what you need to know every step of the way, and that reduces risk. Studies show a direct correlation between blood gas management and reduced complication rates. The CDI System 500 has been earning the trust of cardiac hospitals and cardiovascular surgical teams for almost 20 years. It provides continuous monitoring of 11 of the most critical blood gas parameters, utilizing industry-leading technology. During cardiopulmonary bypass surgery, the shunt sensor can be placed in any arterial or venous shunt, or purge line with continuous flow. The shunt sensor uses optical fluorescence technology to measure PO2, PCO2, pH, and potassium in the blood. 4 microsensors and a thermistor well are in direct contact with the blood to accurately and rapidly measure the values. Light-emitting diodes direct light pulses toward the microsensors, which contain fluorescent dyes. The intensity of the fluorescent light from the microsensors will vary depending on the levels of PO2, PCO2, pH, and potassium in the blood. The photodetector measures and converts the light to numerical data, which is then displayed on the monitor. Blood values are always current with virtually no gaps. There is no need to make difficult judgments about when to draw a sample. Gas source or oxygenator failure can be rapidly detected. Continuous monitoring is especially beneficial during procedures on young or old patients, or with smaller perfusion circuits. Peer-reviewed clinical evidence supports the value of continuous blood gas monitoring. Contact your Terumo sales representative for a demonstration, or visit terumo-cvs.com.
Hello, this is Stephanie with HET Perfusion. Oh, okay. We have an open heart 1 month from today, 9 a.m. start. Oh, really? A single vessel off pump? No problem. Thank you. Hey, Mom, can you bring me a sandwich?
If you'll excuse an expression I use, I'm in love, I'm in love, I'm in love, she's in love, I'm in love,
Oh, thanks, Mom. You're the best.
You having a rough day, baby?
Oh, working for HET. So hard, huh?
Stephanie! Go on the pump!
Okay.
Is that better?
I'm like smiling now.
And welcome back to the program. I'm going to go ahead and go through my slides, and while I'm talking about my slides, I may ask Stephanie to interject or ask some questions.
Okay.
She's way more, I think, intuitive about this. She's more clinical than I am, but there's some I think really good points that Dr. Lumsden brought up in his presentation, and I think it's very provocative. And I don't know how you feel, but it makes me wonder, what are we really doing? I mean, I worry about it. I mean, I kind of didn't worry about it because it wasn't in my face. Mm-hmm. But I think that him and his group at Houston Methodist have sort of shoved it in our face.
Well, I'm hoping it's going to show that all of the things that they're doing are creating more emboli than what we're doing with the pump. That's what I'm hoping.
But shouldn't we try to? Shouldn't
we
our
should.
goal
We've
be
been
zero
talking...
emboli from the pump?
Agreed.
Mm-hmm.
So, and we should compare, and now that we have the integrated filters and we took out our arterial line filter, if that's making a difference. And I think I think you just got to go through a process of one study at a time, you know? Mm-hmm. What do you think?
Well, yeah. So what's your view on TCD during every procedure? Heart.
Well, I really haven't used it personally, so I think we need to get it in a hospital, have a partner surgeon, and just start seeing. If it's going off all the time, like I think some of you have probably seen Dr. Matoyer on here talk, he's going to be ticked off if bloop, 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 it's going off all the time, right?
But I don't
so
think they have to hear it.
We need to hone down and figure out what we're really studying and what we're looking at.
Well, I guess it depends on why we're using it. In other
Right.
words, if we're using it to confirm flow, then I would think you could turn the volume on the blip counter, the emboli counter down. I don't think that's required to have that up like it would a pulse ox.
But I mean, if you're really using it and there's something happening, you want to address it right away.
Maybe not too loud, maybe just only loud enough for us to hear it. Whoever the monitoring responsible party is.
Right.
Maybe there needs to be somebody in a different room that's
so that he
listening to
doesn't
it.
hear it. Yeah.
Right.
I would agree.
Well, I mean, that's true. I think most surgeons are like that.
They wouldn't want to be distracted with that.
Right. They don't want to be, right, exactly, because is it artifact? I mean, if we get a jumping venous line, that might cause artifacts, which will also make noise. So
maybe we need to do some animal labs and figure that out.
We do. I think we need to.
That's what we need to do. Actually, you should tell everyone what we did down at the Mighty Center. It was a really great experience.
Oh, with the boot camp, you mean? Why don't you tell them?
Okay. I had the pleasure of going down with Joe to do a resident, cardiovascular resident boot camp. So we spent the whole day.
And anesthesia.
And anesthesia, you're right. Spent the whole day. They were from all over the country, right, Joe?
Yes, all over the world.
And we got an opportunity to see how they really study, practice, go through things. And I think we need to take advantage of those opportunities and do some of the things you keep talking about every week. That we need to clear some things up.
I think so. And I think you bring up a good point. I think all of us have an experience somewhere, wherever they may be. It doesn't matter. You could be in a private practice in Paducah, Kentucky, or you can be, at Houston Methodist, Cleveland Clinic, Texas Heart, or you could be in the Woodlands, Texas. The Woodland, or what's another town? Not Fredericksburg, but where was that fellow from that came down? Fredericksburg, it's a neat little town. That other town that guy came down to learn the hyperkalemia from. Well, Lufkin. We'll just say that.
Lufkin. Okay.
Where you have an experience, and I think we don't necessarily share experiences with each other all that well. And given the small size of the fraternity of perfusionists, what are we? We're 4,200 plus or minus. I don't know. There's a Texas Society of Texas Perfusionist Society in the state, largest state in the union, and we don't have it. I find that odd. So that's Dr. Mack's talk that I was referring to when I asked Dr. Lumsden that question. And this is looking at SAVR. You know, Dr. Mack is really, really, really big on TAVR. And when all that information came out about how bad TAVR was on stroke rate, he's like, well, wait a minute, whoa, hold on a second. Surgical aortic valves are not benign, okay? You don't not have anything. So he brought this data up, and 61% of their studied patients using the diffusion-weighted MRI that Dr. Lumsden was talking about, 61% had a radiographic infarcts. So they had those new lesions. Any clinical stroke was 17%, and moderate to severe clinical stroke, you know, the ones that everybody considers a stroke, the obvious ones, was 4%. That's still pretty doggone high. You know, you think about, especially there's so few aortic valves done anymore, so many of them are going to TAVR. But he looked at these two devices, basically, cerebral embolic protection devices, the old Embolic catheter, which is on the right, and as you're looking at the screen, on the right side of the screen as you're looking at it, and the Trigaurd embolic protection cannula. I've got some slides on that actual device on the left. And, you know, basically the Embolics worked by, well, let me see what the next slide, here they are right here. So the Embolics worked by, let's see, is this going to work? Or do I have to turn it on? Hold on, it's not turned on. Oh, let's see if it's going to work now. There it goes. And there it goes. Okay, I think it's working. Not very well. Okay, I'll just articulate it. So if you look at the left side of the screen, oh, what happened?
You can use
No, I don't need it. I'm good. I just want to go back to where I was at. I'm like all over the map here. Here, and you go back to that. Slide 4.
Okay.
Cool. Great. Okay, so the Embolic catheter, you would take that net and you would insert it into the aortic cannula when you were going to apply the cross clamp or take the cross clamp off, and then it would capture, and it was proximal to the heart from the actual flow portion of the cannula. But it was intended for if you did an aortic valve and you had calcification or whatever, or debris in the ventricle or around the annulus, it would capture that, and also the atheroma that occurs from applying or removing the cross clamp. On the right side, the Trigaurd is a cannula that also proximal to the heart is actually a suction, and that goes with a roller pump and sucks about 1 liter a minute back up through there, and there's a net to capture so you can verify what you got and also not put it back into your venous circulation, any debris that comes up. And I've got some interesting images with all of these things. But so the concepts are similar, but those are the two devices. And this is
so when did these come out?
Well, the Embolic is off the market now, but it's been around for, I mean, at least 10 years, at least. Probably longer. And the Trigaurd, I'm not exactly sure when it came out, but this is the first generation. There's a second iteration that's coming out. I'm not sure what the differences are, though. It's not been released, and they kind of keep that.
So it's just on trial right now?
No, the Triguard has been used before. It's the second generation that is on either on trial or they're getting ready to release it.
Okay.
I'm not 100% positive about their FDA approval, but I'm pretty sure. I'm confident the Triguard is available for purchase through Medtronic, I believe.
Okay.
We can double check that, but I'm pretty sure. So these are the nets and some of the debris that has been removed from the Embolic catheter. And as I had mentioned, Dr. Lumsden, that, okay, every one of these things has captured something, but the patients still have the same outcomes. And so it makes you kind of wonder, and I'll show you that with Dr. Mack's data that he
I mean,
that
it
he
has
put
to
out.
be minus that.
Minus that, yes. But
So
why does this
it can't
keep
be
going,
the same.
doing? I don't know what the heck the problem is. I'm hitting the wrong button is the problem. Okay, so yeah, exactly, minus that. And those are some serious things. I mean, I agree. That's going to cause some big problems. I can't dispute that. But if 4 of the 5 went through, the question isn't it? I mean, for me, I understand your point. It's better to not had that.
Right.
But if that's only 20% of what actually went through,
then we have
what's
to do
the
better.
point? Right, exactly. Yes. I mean, it seems intuitive that without that is better, but again, if it's 20%, 30%, even 50% of what actually went through, I don't know. I mean, it's a good question. I don't know the answer to it. So, but in summary, and I think these are the points that I found interesting. In patients undergoing SAV or surgical AVR, the use of these 2 different protection devices was not, this is very important, was not associated with an improvement in freedom from clinical or radiographic infarctions, clinical stroke, overall volume of CNS infarcts by MRI, or neurocognitive outcomes at 90 days. That really says a lot. That what's the point of those devices? Now, again, there's a second iteration, but there's no difference.
Okay, well, let me ask you this. In that 61% you showed me where there was some type 2, okay, so you only need to show up how many things in your brain before you go into that category? Not very many, right? Like 1.
1, yes. Any new lesion.
For you to say that these aren't effective because there was 1 at least.
Yeah, but it says neurocognitive outcomes at 90 days. And this may be comparing the 2 different devices, not a device or no device. So comparing the 2 different devices.
I was just saying you can't really say that it's not effective if 1 shows and then that.
Well, I would agree with you. I think that makes sense.
Okay.
I think you're right.
Okay.
But it was associated, with capture of embolic debris in most patients, a reduction in delirium, so I don't know how that could be, based on the first part, and an observed difference in infarct size distribution with fewer larger volume infarcts, but there was an increase in adverse events with the Embolic catheters compared to that of the Triguard. So I think that he's saying that the Triguard is a better choice. Here's that NeuroArc study that our group, one of the studies they did that Dr. Lumsden talked about, and I think this is a, let me see if this is the slide I was looking for, because there's one particular slide. Okay, that just shows you, percentages, severe stroke, mild to moderate stroke in the various different studies, kind of like a meta-analysis. But this is the one I thought was interesting. So look on the right, and you'll see, no, that's not it. Go one more. That's it, right there. So any debris in the Sentinel trial that they did, any debris when you do TAVR was in AVR studies was 100%. But look at the material that it is. I have to take my glasses off. 90% of it was arterial wall. I mean, that's in 90% of the cases. Valve tissue was 50%. 50% of the cases had valve tissue. Over 50%, or about the same, was calcification. Foreign material, I'm assuming like pieces of suture, was about 40%. Myocardium was around 30%. Necrotic core and organized thrombus was relatively low. Acute thrombus was very high. and acute thrombus plus tissue and foreign material, all three combined was almost 90%. That's amazing. Amazing that 90% of the cases had all of that stuff in it. Foreign material, acute thrombus, plus tissue.
It's amazing.
That's a lot. Let's see, what happened? Oh, I always hit the wrong button. Okay, so let's go to that Triguard thing. So let me show you this cannula. Yeah, there it is. Okay. So this is this Triguard. Now again, I think this is the first iteration. So that kind of shows what their mission is. And the concept, unlike the net, the Embolic net, is that you're sucking. So as you put the clamp on, take the clamp off, or remove the clamp and reinitiate cardiac function after an aortic valve or aortic procedure, 1 liter a minute going through there is going to suck preferentially that debris. You know,
I don't know.
I don't buy it.
I don't buy that.
I don't either, but they do,
But,
you know, but
maybe. Well, you would have
it's going to capture some. So by your earlier argument, isn't that better than none?
Okay, you're coming down on flow. You're probably going to be at what, 2 liters?
Yep.
Then you're going to put your suction on at 1 liter.
Yep.
I just feel like there's so many things that can go wrong with that.
Well, we need to find out, because this may be a really good cannula, and if it reduces,
It might. I need someone to call in and
at
tell me that.
all, by your argument, it's better than not at all, right?
But looking at that, I feel like there's a better way.
Okay.
Okay, but
Okay.
I have no experience with it.
So here it is, right here. The majority, and it's also good for gases, which the Embolic really isn't. The majority of, which is a very good point. So if you do have GME or you do get an air embolus, you do. This is more beneficial. Now I don't know how it's going to take it, because
basically
the tip is distal. So the tip is distal.
That won't work.
So I don't think it would work.
I don't think that would work
either too terribly well. But that's
in
the
theory,
concept.
well, if it was turned the other way, it sounds great, but
if it was sucking further up,
Right.
further out.
Right.
Right.
Okay.
So here's the system set up. So you see the oxygen, the return flow going into the arterial cannula, which would be the cannula on the top right, on the right side of it, and then the vent, and a filter at 40 microns to see what you captured coming in on the left side. And then I guess this is a clinical study, kind of gives the outline of it. That's the scientific advisory board. Dr. Mack is on the advisory board. And this is some of the stuff that they took out.
Actually took out.
And this is surgical now. Remember, this isn't TAVR. This is SAVR. And it may not even just be aortic valve. It could be, this could be coronary for all I know. Just take it and put it in the clamp on and take the clamp off. I really don't know. They sent me these slides, but they're keeping a lot of this stuff top secret. And that's, of course, just an image. We saw that from Dr. Lumsden. You can see the bright white spots as the new lesions for that kind of thing. And then that talks about percentages and all that. I really don't feel like we need to go over all these things. But it decreases hospitalizations, obviously, when you know, compared to the control. And so in their conclusions, I think we'll just go ahead and get to that. The use of the system is safe and easy. Emboli were captured in each treated patient. Size of the largest emboli, mean was 1.7 with the largest 3.6 millimeters. Significantly less brain lesions in those patients that used that device. And diffusion weighted MRI, 54% reduction in average total volume or new lesions, and or maybe also lesion size or distribution, you know, the distribution effect, and then a 39% reduction in patients with lesions at all. So of the number of patients that did have lesions, new lesions with open MRI, they were able to reduce it by 39%. So that's, I mean, those are all pretty significant. It may not be statistically, but it is
I'm just
significant.
biased and just have a feeling or something that I don't like it. You know what I mean? Maybe it's a great cannula and I just don't know.
I don't know either. I've never
What
used
do you
it.
think about if you just had the
And you
filter?
turn the phone lines on. Let's go ahead and cut the slides. Yeah, we got the
Okay,
slides cut. Just
so-
go ahead and open the phone lines up, and Steph and I'll just
What would
chat
be
about
different
this.
then, throwing it out there? Just taking your aortic root vent and putting a filter in it.
Because I think the lumen size, I think that is, if you're getting a liter
Because
a
you
minute
couldn't get a
through that,
liter, you don't think?
That's no, not without.
Maybe
I think
half,
It's a, I think
maybe
it's
half a liter.
Yeah, I think a root vent is what is that? That's
You could have a bigger root
it's
vent.
what is a root vent? It's
12
12
maybe,
French?
12 French.
12 French, yeah.
But you could,
So I
I
don't
mean,
know
you
what
could
the lumen size
increase
on
the
this is.
size of a root vent.
Well, then you're putting yet another hole in the aorta that's much bigger.
Okay.
You know, this is a dual-purpose, dual-lumen
Okay.
cannula, so it's a
Throwing it
single
out
hole.
there.
Yeah, it's a good thought, but I mean that may work. I don't know.
I don't know
And
either.
it may be better to have a vent. Of course, people don't mind sticking holes in the aorta. Most surgeons don't. I mean, I don't think they like making extra holes, but they will. And maybe we should have something.
I mean, it wouldn't be an extra hole because they already use it, a root vent. It would just be a bigger hole.
Yeah, but I
right?
think position matters. I think position matters, right? So your root vent is going to be proximal to your aortic cross clamp. So when you to give the cardioplegia.
Yes, that's true.
So you would have to add the other vent,
Just for the cross.
and then you have one more vent to play with, and of course you have it with this
That's
anyway.
true.
You still have it, but I guess you turn it on and kind of forget it, sort of. Or they say turn it on when they're
You
applying
wouldn't want
or
it
removing.
on
Right, you
all
wouldn't
the
want
time.
it on all the time.
I mean,
right.
that would be a
But why
high
not?
percentage of
Maybe
your
you
flow.
should want it on all the time. Well, you turn the flow up.
And what is that doing with laminar flow?
I don't know.
I don't
That's
know.
a good question. You know who we need? We need
Who do we need?
Erica. Erica,
We
you
do.
need to come
Erica,
talk to
I'm
us
being hard on
because
your
we can't
device.
figure this thing
You need
out.
to
Yeah,
call
and
me.
Bob Peacock
Yes.
too. Bob,
Being
if
hard
you're
on you.
watching, you said you were going to be watching tonight. So Bob, I'm calling on you. I'm telling you because we don't know what the heck we're talking about. We're just out here guessing. I'm thinking about the Philly cheesesteak sandwiches that Stephanie brought for us for dinner tonight. And anybody on the web that wants to come, you're welcome to come. But and just find the studio if you can hurry up. But I think we need to get Bob Peacock
think
over
so.
here to talk about this cannula because it's existed. I've never heard of it.
I haven't heard of it. I don't think I know anyone that uses it. Do
Because
you?
all of our guys used Embolics. And now
And how did they like that?
they loved it. They thought it was because it always
Why did
captured
you stop?
something. Because Edwards took it off the market. I don't know why.
What I'm thinking
There's
mainly
rumor.
is that there's a lot of room for improvement on both.
I think there is too. Okay, anybody want to call in? We do have the phones open. I'm going to check the chat line one more time and see what's going on here. I don't see anything. Oh, wait. I disconnected myself when I closed my computer. Give me 1 second. And something will come up here. Okay. Say something. Just don't take the camera
What?
off of me. Put it on to her.
No. What am I supposed to say?
I don't know.
This is your talk.
Say something.
Joe went into work for me like a couple hours this morning, and now I'm indebted to him to sit here.
4.5.
Is that a good trade-off? How I'm gonna sit here for 2 for your 4.5. So I guess I won. Okay. That's a poor argument on my point.
Okay, I don't see any questions at all. So with that said, I think we ought to. I mean, we got a lot of material.
I think
covered,
I think we need to have a Medtronic in here, and I want to see how that works.
I agree with you 100%. Okay. With that said, we're going to end early so you guys can get to your maybe DVR television programs, or you could get to dinner, or you could, I'm sure you probably sat there, with your TV tray, your TV dinner, watching this.
Us.
There's no question, there's no doubt in my mind, everybody out there in web world did that.
With probably a full bottle, I would say.
That's empty now. All right. Good night, everybody.
Good night.
We'll see
Thank
you
you.
on Thursday. Our program on Thursday is a debate
It's going to be a good one.
Pros and cons of state licensure. Deb Adams is going to be here, as a matter of fact. You're going to be here. Rodell is going to be here. I'm going to be here. And it's going to be a great program. We got some great programs coming up, too. Patrick is going to be guest hosting for me on September the 11th, which is going to be great.
That's
you got to be here
great.
to support him.
I will.
And then he has his program on the multi-camera view of the pump and the operation and all that stuff coming up on October the 4th, I believe. So check that perfweb.us and make sure you know what our schedule is and log on and all that. It's free to just watch if you just want to watch and participate. And thank you for the webinar from Scott Boulay. Thanks, Scott. I appreciate that very much.
So everybody tell your perfusion friends to listen on Thursday.
Yes.
Call in because it's a state licensure discussion.
Yes,
and
pros and cons
pros
of
and
state
cons
licensure.
is going to be a big one, I think.
18 and 26. Anybody know what that means? What do you think that means, 18 and 26?
I don't know.
18 states have state licensure in 26 years.
Wow.
What does that tell you?
Well, I don't know why I'm in a state that has it then.
They did it for you.
Yeah.
See you next week, or
All
on
right.
Thursday. See you Thursday.
Good night.